Next speaker, I'll invite Dr. Kishor Choudhari. He will talk on the best way to manage intraoperative aneurysmal rupture. Choudhary, please.
Respected Chairman and the colleagues, I come from Sheffield in Yorkshire and I'm one of the neurovascular surgeons there. This is a very well-known sentence by William Hansted, who said that the only way an unconscious patient can retaliate is by intraoperative hemorrhage. We always try our best to prevent it. The key factors when influencing aneurysm ruptures are very well known. If it's a rupture or unruptured, what's the timing of surgery, what's the location of aneurysm, and the aneurysmal morphology. We all know like tiny blister-like aneurysm or dark aneurysms are more likely to rupture. And of course, experience of surgical training, whether it's an occasional surgeon or a dedicated neurovascular team. The literature is varied. I will just summarize it. For ruptured aneurysm, the intraoperative rupture rate is 10 to 25%. Combined ruptured and unruptured is 5 to 20%. Average is about 15%. In complex cases, up to 25%. Nothing surprising. At our institute for last 3 years, our rupture rate has been about 15%. Our lead surgeon in most of the cases is actually a neurovascular fellow, not the consultant. We are very hands-on training on our senior registrars and fellows. And as expected, many of them have had poor outcome simply because of rupture. This is how a typical ruptured aneurysm looks like. This was just before a rupture happened from an MCA aneurysm. You can see a clot coming up. And then because it ruptured, the video was stopped, and that's all I have. Our preventive strategies, especially mine, are as follows. First of all, the most important thing is preoperative planning. Cannot emphasize more. CTA, DSA, MRA, whatever you want. Study the dome, neck, lips, perforator, collateral circulation, etc. We need to identify all the high-risk aneurysms and which are rupture-prone zones. Optimizing BP and coagulation status. You will be surprised how many patients are on antiplatelets and anticoagulants nowadays. Team brief in the morning when you are starting your case is important. We always discuss rupture protocol with anesthetics, including hypotension, burst suppression, adenosine, etc. in anticipation of the rupture. And in a surgical team, if there are two or more surgeons, a fellow, senior registrar, SHO, there should be a clear chain of command among the surgical team members. Who's going to do what at what stage? Who's going to do what when something happens, etc. Preoperative surgical preparation we are all aware of. Equipment readiness, microscope, adjuncts, suctions, tapes, temporary clips, hemostatic agents if you're using them, I don't. ICG, Doppler probe. Position has to be comfortable for surgeon and assistant. If a fellow is operating, it has to be comfortable for him. Optimized lighting, magnification, focus and zoom speed are all important in preventing rupture. Brain relaxation strategies. I do not use mannitol or lumbar drain or furosemide or hyperventilation for any ruptured aneurysms anymore. I used to do that long time ago. I don't find the need to do that anymore. And I prefer to maintain adequate MAP all throughout the procedure. Just to give an example of preoperative preparation, 34-year-old man, grade 2 subarachnoid hemorrhage, right hemiparesis. This is what we thought we could do. We debated about STMC bypass, but I thought I could get away with the clipping and reconstruction of M1 preoperatively. This is what we found and what we did when we exposed it. And this is the post-op angiogram. Not only aneurysm is split, M1 reconstructed. The post-M1 circulation is also improved. So this is all because of preoperative planning. Surgical dissection. I don't need to emphasize that the craniotomy has to be adequate. Opening of perioptic cisterns, very important in my view. I use lots of cottonite patties and retractors to protect the brain. I'll come to that in a minute. Sharp dissection is called blood dissection, and identify only the neck. You do not need to dissect the dome or expose the entire aneurysm. Most of the cases, the aim is to clip the aneurysm, not to show off by dissecting the nail before clipping. And clip application has to be slow, deliberate, gentle. No rushing, no shearing. Some examples of dissecting rupture aneurysms without causing rupture. This is an ACOM aneurysm, blister-like, and it can be dissected without any intraoperative rupture. Another ACOM aneurysm in a previously coiled aneurysm, but this is a de novo aneurysm which has bled. Again, all A1, A2s, ACOMs, everything can be dissected without rupture. MCA aneurysm, this is M1, one M2, and another M2. This is the rupture point, and it can be dissected without causing intraoperative rupture or temporary clipping. Number of times I use supraorbital craniotomies, and even complex aneurysm like this can be dissected, clipped satisfactorily without intraoperative rupture. Some of the nuances in avoiding rupture, I try to use a small suction tip. I do not reduce the suction strength. I just use a smaller tip. Individual preference. Couple of things. I'm saying that please be careful when using instruments which offer false reassurance. One is a ball dissector, which is not as non-traumatic as you would think, and suction tip and bipolar cautery. Many people have a habit of coagulating aneurysm unnecessarily. Avoid that. You will save some patients. I do use retractors for optimum dissection. Number one, to protect the brain, then to retract. Number two, to keep all the natural spaces open like Sylvan fissure. Number three, to provide adequate traction on the arachnoid which can be divided. And number four, I use it to put traction on the dome of the aneurysm, on larger aneurysms, for better visualization of the neck, especially in basilar and MCA aneurysms. 6 common errors in clip application are hasty clip, failure to open the blades fully when readjusting, improper size or shape of the clip, not fully identifying the neck, inadequate clipping or shearing of the wall, and not appreciating thrombus. This is one of the cases that one of my fellows was doing, and I'm always there, but I give them full hand in operating, even if it's ruptured or not ruptured, and I will just skip the video for the time being, for the want of time. Sorry. How do I go back on this? Yeah. One more important thing that I find very helpful is keeping the field weight all the time. That's why I don't use lumbar drain. And this is a simple PCOM aneurysm that was uncoilable. And look at the CSF. But for me, that's not enough. I always use more, I put more saline, keep it empty, keep it wet, so that your surgical blades do not shear the aneurysm. And then, even if you're readjusting the clip, usually that's not a problem. Commonest cause is drying up if it's a rupture. Just to conclude, this is my team. To conclude, intraoperative aneurysm rupture, in my opinion, is almost always a preventable technical error, and its prevention is the best strategy in microvascular surgery for rupture aneurysm. Thank you very much for your patient hearing.
Thank you, Dr. Choudhary.
Call Daniel Walsh.